So coming out of last year's summit, we felt compelled to really focus on some of the practical issues, and we've been over most of them today. But our survivor survey focus groups gave a very compelling message that whatever we could do to facilitate earlier stage diagnosis would be greatly appreciated. So, this is a fairly typical testimonial. And we've touched on these issues today, but once again, you can see that a major issue are the challenges of timely diagnosis and making sure that our providers, as well as patients and families, are really tuned in. This is exactly what Dr. Annan was saying just a few minutes ago. This is a key issue. Now, trying to maintain the momentum, but to keep this in perspective, as has been touched on by some of our other speakers, some people are inclined to say this is not such a major cancer issue. Of course, it's a huge cancer issue. As Rebecca Siegel reminded us, we're talking over 14,000 cases a year in the United States. That exceeds all Hodgkin lymphoma, acute lymphocytic leukemia, chronic myeloid leukemia, and even cervical cancer. Right? So this is a major cancer control challenge, no matter what anyone tries to say. And then just a quick reminder, again, the incidence under 40 as we look around the world, as we've seen, the West is somewhere down here. But these are a variety of studies that again demonstrate that as we look around the world, and as you've seen from our presenters, these rates are... So any alarms that we hear will actually be alarm. Well, in a weird way, you'll never forget this talk, right? Thanks to them. All right, so as we've seen and as we've discussed, moving right along, the trends are most dramatic for left-sided cancer and rectal cancers in particular. You can see these incredibly dramatic increases that we've already discussed. And also these dramatic increases in regional and distant disease, which are really, very striking. And also these very dramatic, the most dramatic increases, again, as Becky showed us, are in the youngest age groups. This is the canary in the coal mine, which you can see here. However, as Dennis and others have reminded us, 75% of all these cases do occur in people aged 40 to 49. And if we just followed our own evidence-based risk guidelines, we could have a huge impact. Now, this is a terrific paper. I know the audience has thinned, but I just want to stress this is great. And as it happens, 5 of the authors of this paper are here or were here today. So Dr. Annan is our lead author. Whitney Jones was here. Jasmine Greenemeyer was here. Stephanie is still here. And Dr. Yu was sitting right there as of a couple minutes ago. So I really commend this paper to all of you. It's rich in valuable information, and it also provides a great intellectual framework with which to think about some of the issues. So Dennis's team made some really profound points that are worth underscoring as we wrap up today. 86% of patients with young onset colorectal cancer are symptomatic at presentation. That's obviously bad news in that there's a higher likelihood of advanced stage disease, and that impacts outcomes. So very important. And again, similarly, but not exactly the same thing, they were able to present literature evidence to show that young onset CRC is more likely to be detected at an advanced stage, and these patients are much more likely to have advanced stage disease than older patients. And this is ostensibly the same points. And young onset patients who are African American and Medicaid insured or uninsured were also more likely to present with late stage disease, and of course this is probably to do with access to medical care. So moving right along, what is the problem? Well, the problem is somewhat complex and multifactorial, but there are rich opportunities, as we've heard today, to really make a difference. So I divided this up into pre-symptomatic strategies, and then supporting more rapid, effective response for the symptomatic patient. So in terms of pre-symptomatic strategies, this is exactly what Dr. Annan and others spoke about today, and that's really all about risk assessment and assessing risk based on family history. We've been over this, but it cannot be stressed. It cannot be overly stressed. And then secondary risk stratification, as Dr. Nguyen mentioned and others, there are these other risk factors that we need to consider when we look at our populations and individuals in our clinics and our offices if we're considering what is the possibility of rectal cancer. And again, this is just data from AACR reminding us of these risk factors which we've seen today and their strong correlation with increased risk. So for symptomatic patients, as we've touched on, but just briefly, we have provider-related delays and we have patient-related delays. All right? And so again, when patients present to their providers, there can be delays. Missed symptoms, misdiagnosis, and this affects a very significant percentage of cases. So there are huge opportunities here for provider education. And then there are patient-related delays, which we've seen from work around the world. So people don't necessarily recognize the significance of the symptoms they're dealing with. They're young, they're previously healthy and otherwise strong. It's hard to put it all together. There's embarrassment, there's fear, denial, lack of access to care. We're going to touch on some excellent work from the UK with Professor Hamilton, who really looked at this within the NHS, and the results were exactly the same. So bear with me here. So we wanted to really try and assess this and think and reach out and see if there were any models out there that could guide us how to move forward with these problems. And a dramatic example of how we might move forward is the work of Dr. Barbara Goff, who developed the Ovarian Cancer Symptom Index. So keeping things moving, Dr. Goff was responding to the fact that many women with ovarian cancer were thought to be asymptomatic, and it was referred to as the silent killer. But in fact, many of these women had significant symptoms. So keeping things moving, I'll just share that Dr. Goff made a huge effort to actually survey these patients and qualify and quantify the specific symptoms that women with ovarian cancer had. Now, this is a little busy, but I just want you to get a sense of it is possible to construct these surveys. It's possible to get them done. She did this on over 1,700 ovarian cancer patients, and it was an extremely valuable exercise in which she was able to assess the significance of vague abdominal complaints, bloating, abdominal pain, and remarkably, very few people actually had GYN symptoms. They were more generalized symptoms and signs that proved to be significant. And I want to draw your attention to the fact that, the key issues were the duration of symptoms and the fact that even women with early stage disease had significant symptoms. And that's really, really important because it underscored that if you did this, if you use these indices, you could really facilitate earlier stage diagnosis. So that brings us to, as we try and wrap up, the situation for young adult colorectal cancer. So this is not an endorsement from the American Cancer Society. This is just a reminder that these are the colorectal cancer symptoms and signs that are on the American Cancer Society website. You can see the website here. So this is it. So this is familiar to all of you, but these are the key symptoms and the sign of anemia, which has been referenced multiple times today. So keeping it moving, what I did was I tried to go through the literature and find papers that really helped put this into perspective. So I'll move through them quite quickly. I'm not going to read them. You can see the titles. You can see the authors. Not surprisingly, this paper is from the United Kingdom, once again. But here are some take-homes. The rate of colorectal cancer among men and women with rectal bleeding is approximately 25 times that of the general population. So many of my GI friends say, look, I can't scope everyone who has rectal bleeding. I'll be here till midnight every day of the week for the next 20 years. We have to individualize, we have to interpret, and again, duration of symptoms, but the bottom line is if people have persistent rectal bleeding, there may well be an issue, and as we heard earlier today, even if you have hemorrhoids, it's not mutually exclusive. It's very, very important. This is a very nice review from our colleagues in Canada. Let's look at the take-homes. So rectal bleeding. 21 primary studies provided positive predictive values on rectal bleeding as a single presenting symptom associated with rectal cancer. All right? And in more than half of the studies reviewed, this risk was significant and exceeded 5%. And these are the positive predictive values here. None of this is a surprise, but it's the documentation. It's the documentation in people with rectal cancer that these significantly correlate with that diagnosis. This is from Jim Church's group at the Cleveland Clinic. Rectal bleeding is a common symptom, especially in combination with anemia, and should be thoroughly investigated. All right? Thoroughly investigated. And the presence of a second symptom doubles the absolute risk of colorectal cancer in individuals for all age groups if you have rectal bleeding. It's from the Cleveland Clinic. Moving right along. So this is from the American Family Physician, and I deliberately put this in, because obviously we need to make successful outreach to our primary care physicians. We've been talking about them all day long. Next year we have to get them here. But you can see for the busy primary care physician or the GP in the UK, these issues have to be balanced. So here you can see them struggling with this issue of rectal bleeding and anorectal symptoms in people under the age of 40. They know the numbers are low. However, if the source of bleeding cannot be confirmed or if bleeding and anemia continue, a colonoscopy or some endoscopy should be performed for complete evaluation of the large bowel. All right, so these folks were extremely busy, time and resource constrained. There is a consensus that these symptoms need to be taken seriously. And then moving into the last lap here, this is an outstanding paper by one of Deborah's colleagues. Professor William Hamilton is here. And this is a really exquisite piece of work looking at issues that contribute to patient delays and system delays in diagnosis of patients who ultimately prove to have colorectal cancer. So I tried to get this down to a single punchline. So what Dr. Hamilton and colleagues wrote was that their findings provided some guidance for awareness campaigns on reducing the stigma around appraising and discussing bowel movements, because that's the bottom line. Patients had these symptoms and signs, needed to talk about it, and that what might seem to be nonspecific symptoms could be extremely, extremely relevant. So altering perceptions about the appropriate use of health services also. You have this amazing phenomena in the UK where patients, quote unquote, don't want to bother the doctor. They don't want to burden the physician with any extra work. You need to educate and empower people to seek medical care and diagnostic evaluation. So again, coming back full circle to where we started, again, complex problem with requiring pre-symptomatic and as well as rapid effective response for the symptomatic patient. So this brings us back to the list of symptoms from the American Cancer Society. And so we are working to advance a risk score inspired by Dr. Goff's work. And the practical steps for this require a survey of survivors, which we're working on and is under IRB review. Again, following the example of Dr. Goff, this will entail cataloging symptoms, looking at duration, frequency, require validation, including prospective analysis, integrate known risk factors, and also integrate physical signs into this model. Now, this is one of Deborah's slides, and again, this is Professor Hamilton's work in an older population. Deborah was careful to stress this has not yet been validated in younger colorectal cancer patients, but I have to be honest, I know she was careful to clarify. I think a lot of these symptoms will translate. We just need to do the validation. We need to do the validation work. So, moving forward, we have the Ovarian Cancer Symptom Index as a model. We have the progress reported by Deborah and Professor Hamilton in the UK. We have a charge from the roundtable to move forward as rapidly as practical, as Dennis was referring to, develop tools and identify those at increased risk to dramatically improve earliest possible stage diagnosis as rapidly as possible. So with that, I want to thank you, and if we have any quick questions for any of the remaining folks here, we'd be happy to do that. I think we're pretty much set to, I think we're pretty talked out, right? So we're going to move, let me just, thank you. So, on the program, on the program, we next had next steps, right? So I'll just, we put this together on the fly, and this is just based on the 4 primary sessions we had today. So for global trends, we are working on a review article where we will involve a number of our presenters to dig a little bit deeper on the global trends. Our Quality of Life Symposium, we look forward to working with Martha and Dr. Peterson to highlight the key points there and look where we need to go in the future, both practically and in terms of research. The epidemiology, we had a range of fantastic presentations, Dr. O'Keefe and others. So, there are rich opportunities there, and we hope to be able to facilitate the formation of working groups to address these issues. And again, reducing mortality, as Dennis said, really we need to identify those at risk, and we need to facilitate earliest possible stage diagnosis.